Good morning, ladies and gentlemen. So today is my last lecture from the chapter Dermatoses of the Neonate. And in this lecture, I am going to discuss the neonatal infections. Before going to the individual diseases, let's revise the differential diagnosis of bully or erosions in the neonate. So the common disorders that results in bully or erosions are the miliaria crystallina, bullous impetigo, thermal or chemical burn, or the sucking blisters. And rare conditions include mastocytosis, several infections like neonatal herpes simplex, fetal varicella syndrome, herpes zoster, and congenital syphilis. We will discuss these diseases today. Passively transverse antibodies from the mother may result in neonatal pemphigus vulgaris or pemphigoid gestationis. We have discussed already these diseases in the first lecture from the same chapter. And then bullous pemphigoid. So the infections during neonatal period. The first infection we are going to discuss today is the neonatal herpes simplex, which is a serious disease with high degree of mortality. Worldwide incidence of neonatal herpes simplex is 10 per 100,000 live births. And 40% of the affected neonates are born premature. Majority of infection is the result of peripartum transmission of herpes simplex virus type 1 20% and type 2 80% through the contact with infected genital tract during the delivery. So, if the mother is suffering from herpes simplex genitalis, it is likely to transfer this disease to the neonate at the time of labor. However, intrauterine herpes simplex virus infection occur rarely. 5% of all neonatal herpes simplex virus is due to intrauterine transfer of the disease through the placenta. The intrauterine herpes simplex virus is usually due to herpes simplex virus type 2, and the risk is higher when herpes simplex virus is primarily affecting the mother or is a disseminated infection. Infection in a neonate may also occur postnatally by contact with non-genital sites, both maternal and non-maternal. So we have discussed the three types of neonatal herpes simplex. The first and foremost is the transmission of herpes simplex to the baby during labor from the female genital tract. The second, which comprises of almost 5%, are those with intrauterine infection if mother suffers from primary herpes simplex and that too a disseminated one. And the last but not the least is the postnatal acquisition of infection through non-genital contact of herpes simplex virus from the mother or other relatives who are taking care of the baby. Up to 2/3 of the women who acquire genital herpes simplex virus during pregnancy manifest no symptoms or develop so non-specific symptom, so it is undiagnosed during the pregnancy and is a threat to the baby. Hence, most infants with neonatal herpes simplex virus are born to mothers who have no previous history of genital herpes and show no overt clinical sign. Then another figure is that over 70% of all infants with neonatal herpes have skin or mucosal lesions. So the skin lesions appear between the day 2 and day 20. In case of intrauterine infection, the lesions are present at birth. So if disease is acquired at the time of labor, then the disease manifests at the day 2 to 20. And if the disease is affecting the neonate intrauterine, then it is manifest at the time of delivery. It is characterized by isolated or group vesicles, which is, of course, the most common type of lesion seen in herpes. The sites are mainly scalp and face, although lesions can occur virtually at any site. Occasionally, the eruption may be generalized and bullous. There can be widespread erosions without obvious vesicles or bullae that may mimic epidermolysis bullosa, but the new lesions tend to stop soon, while in EB, the lesions keep on developing. When infection is acquired during birth, the initial lesions have predilection to the scalp and face with vertex presentation and perianal area in case of breech presentation. It is also localized to areas of intrauterine or interpartum skin damage as areas of the fetal scalp electrodes or forceps if applied. Areas of cutaneous atrophy or scarring are not infrequent in the intrauterine form, and vesicular lesions may continue to appear within or at the periphery of these areas. Sometimes a zostriform pattern is described. Congenital cutaneous calcification is reported in child with intrauterine herpes simplex virus infection. Oral lesions are also frequent. They take form of erosions on the tongue, palate, gingiva, and buccal mucosa. There can be widespread aplasia cutis. A fetal outcome is unusual in limited infections, but high if the infection is disseminated with CNS involvement, even if given appropriate therapy. Mortality is higher in type 2 herpes simplex virus than type 1 infection. Early recognition, adequate early treatment with acyclovir appear to protect infant from disseminated infection and, of course, the mortality. Herpes simplex virus in premature infant is more severe than fully mature infants in terms of clinical outcome. So in one study, 9 out of 12 infants died and other 3 had a neurological consequence. It often presents as respiratory distress or thrombocytopenia and other non-specific signs and symptoms such as lethargy, hypotension, raised AST levels, and fits. If in doubt, you can send the culture of PCR, and it is confirmed by these ways. The treatment is by intravenous acyclovir therapy, which should not be delayed. Then ganciclovir, it should be monitored for neutropenia, and foscarnet have also been occasionally used. There is insufficient evidence to suggest acyclovir prophylaxis in third trimester of high-risk pregnancies affects the incidence of neonatal herpes simplex virus, although it will lessen with the need for cesarean section. So as compared to SLX prophylaxis, it is better to go for cesarean section and omit the normal delivery if the mother is suspected of having genital herpes simplex virus. The second infection we are going to discuss is the fetal varicella syndrome. Approximately 90% of the adults are seropositive for varicella zoster virus antibodies. If a woman is seronegative, she may develop chickenpox during pregnancy, and this may occur in 10 per 10,000 pregnancies. If varicella zoster virus affects the mother for the first time, there are 25% of chances of transmission to the fetus. Such transmission is very rare in mothers who develop herpes zoster because in case of herpes zoster, the varicella zoster virus antibodies are already present. When a mother develops varicella between the 7th and 20th week of pregnancy, a spontaneous abortion may occur and child may be born with variety of abnormalities, which is part of fetal varicella syndrome. The fetal risk is now 2%. However, most children of such mothers are born with no detectable abnormalities despite of laboratory confirmation of intrauterine infection. So these are the principal features of fetal varicella syndrome, which occur in 2% of mothers who develop the infection from 7th to 20th week of gestation. The first is the low birth weight, then is the localized absence of skin, particularly over a limb. Scars are often of dermatomal outline, papular lesions resembling a connective tissue nevi, hypoplasia of one or more limb with a malformed digit, ocular abnormalities like chorioretinitis, cataract, microphthalmia, Horner syndrome, CNS abnormalities like seizures, mental retardation, hydrocephalus cortical atrophy, encephalitis, encephalomyelitis, and dorsal radiculitis. So the main brunt is on the limbs, eyes, and CNS. Localized scarring is presumed to be a sequel to intrauterine ulceration, which is one of the most common cutaneous features of fetal varicella syndrome. The segmental outline is a direct consequence of damage to fetal nervous system. Area of congenital localized absence of skin without associated limb hypoplasia or other neurological abnormalities is a less recognized complication. Then skin-colored papular or verrucous lesions are also seen. This is a typical fetal varicella zoster virus infection. And on the right picture on the right side shows scarring in a dermatomal pattern. Prognosis and outcome. Mortality in a child with full-blown herpes simplex virus in first 3 months of life. Herpes zoster infection in early infancy is likely to indicate that child has been infected in utero. As the risk of fetal damage is small, termination of pregnancy is not indicated. Ultrasound examination is performed to detect some abnormalities that occur in cardiovascular system, but ocular and neurological sequelae cannot be diagnosed on ultrasound. Management. The pregnant women who are not immune on the basis of on the basis of history and preferably serology, and who are exposed to the herpes simplex virus should be given varicella zoster virus immunoglobulins. Although this can prevent or modify clinical varicella if given up to 3 days after the contact, however, there is no definite evidence that it prevents the fetal infection or the damage. So, if available, varicella zoster virus immunoglobulin should be given within 3 days of contact with varicella patient, provided the mother does not have varicella zoster virus antibodies. Giving varicella zoster virus immunoglobulin to neonates of mothers who had chickenpox at the time of delivery does not appear to reduce the incidence of clinical infection, but it does reduce its severity. There are no reports that establish a role of acyclovir therapy in prevention of fetal varicella syndrome. Therefore, the decision whether to treat the mother should be based solely on the severity of her illness. However, several studies and clinical observation favor the treatment of patients, mothers with the primary varicella who are not having antibodies due to previous infection. The potential dangerous situation relates to the maternal development of varicella 4 days prior to the delivery. In this case, neonatal varicella may occur, but in absence of the protection offered by maternal immunoglobulins, mortality can be as high as 30%. Hence, varicella zoster virus immunoglobulin is recommended for all the neonates born to mothers who are suffering from varicella infection 4 days prior to the delivery. If overt clinical varicella develop in child, intravenous acyclovir should be added to the varicella zoster virus immunoglobulins. The third infection we are going to discuss is also very important and is called as the congenital rubella. Rubella is contracted by the fetus before 20th week of gestation and results in disseminated infection causing intrauterine growth retardation, microcephaly, microophthalmia, and wide variety of other abnormalities. Cutaneous lesions are the most prominent clinical features, and typical lesions are present at birth or during the first 48 hours. The lesions comprise of discrete, round, red or purple infiltrated macules, 3 to 8 millimeter in diameter, generally occurring on the face, scalp, back of the neck, and trunk. The lesions tend to fade over periods of weeks. The lesions are clinically not different from the normal rubella or measles, which anyone can develop in his life or her life. This is the skin lesions of fetal rubella infection. So if we see this picture, it indicates different features of congenital rubella, that is meningoencephalitis seen in 7%, microcephaly and mental retardation, then glaucoma, cataract, and pigmentary retinopathy. Hearing loss may occur, congenital heart disease, hepatosplenomegaly and jaundice, purpura and thrombocytopenia, radiolucent bone disease, and low birth weight. So lots of systems are involved in congenital rubella infection. The lesions also have been described as the purpuric and are attributed mainly to the thrombocytopenia, which is a significant feature of this infection. The histological examination comprises of foci of dermal erythropoiesis. These lesions are described as blueberry muffin lesions. Genuine thrombocytopenic purpura is probably uncommon. Other reported skin manifestations include cutis marmorata, seborrhea, hyperpigmentation of forehead, cheeks, and umbilical area, and discrete deep dimples over bony prominences, particularly the patella. Fewer cases are seen today, and comprehensive vaccination program allow for eradication of this condition. This rubella is part of the vaccine MMR, mumps, measles, and rubella. Then human immunodeficiency virus infection, HIV infection. The HIV infection is transmitted to the infant in utero during the delivery or through breastfeeding. Because most infections are probably transmitted around the time of birth, some manifestations are not commonly seen for the first few months, and some infected infants will remain asymptomatic for many years before the manifestations first appear. Mucocutaneous manifestations are common in infants born with HIV infection and have infective etiology. Skin disease most prevalent and when there is high degree of immunosuppression. The common skin diseases are the infection, which are the dermatophyte fungal infection, and unusual fungi like aspergillus may also be involving. Bacterial infections include recurring impetigo, folliculitis, cellulitis, and abscess formation. Viral infections include atypical chickenpox, herpes zoster virus, herpes simplex, and severe molluscum and herpes papillomavirus. Norwegian scabies may also develop a wide variety of non-infection infectious manifestations include the pruritic eruption of HIV, seborrheic dermatitis, and the drug eruptions most frequent, especially with trimethoprim sulfamethoxazole. Porphyrias may develop like congenital erythropoietic porphyria and transient protoporphyremia, then transient myeloproliferative disorders, congenital absence of the skin, Langerhans cell histiocytosis, and extensive congenital erosions and vesicles which heal with reticulate scarring. The genodermatoses which are seen in these patients include EB, AEC syndrome, Weary and Kindred syndrome, ectodermal dysplasia, bullous ichthyosiform erythroderma, incontinentia pigmenti, and AEC ankyloblepharon ectodermal dysplasia and cleft lip or palate. The fourth condition we are going to discuss is the staphylococcal scalded skin syndrome. It is caused by an epidermolytic toxin secreted by certain strains of Staph aureus, and this epidermolytic toxin may be A or B. These toxins react with the skin via circulation, reach the skin via circulation from a distinct foci of infection, usually from the umbilicus, breast, conjunctiva, or site of circumcision. Transmission of this toxin through breast milk is also reported. These epidermolytic toxin attack desmoglein 1, so mucosal involvement does not occur. This is analogous to pemphigus foliaceus, which has the same target antigen, and the split is mainly subcorneal. The disorder is seen commonly in young children, particularly neonate, due to less efficient metabolism and excretion of this toxin. It does not present at birth, although appear in first few hours. The first sign of disease is a faint macular orange-red scarlatiniform eruption. The eruption gradually becomes extensive over the next 24 to 48 hours, becoming confluent with deepening of redness and edema formation. The surface soon becomes wrinkled before it starts to peel or separate, leaving raw red erosions. You can see these erosions due to peel off of superficial stratum corneum. Site of predilection are central part of the face, axilla and groin, which result in widespread skin denudation. there is extreme tenderness of the skin, an infant are crying, child is pyrexial and distressed, there are presence of impetiginized crust around the nose and mouth, which is of diagnostic significance. Recovery is usually rapid, even without antibiotic therapy, although infant occasionally die in spite of such treatment. Healing will occur without scarring. The differential diagnosis, the scalded appearance of a skin, differentiate the disease from bullous impetigo, and rapid onset of marked cutaneous tenderness distinguish it from other cause of erythroderma in a neonate. The rarity of clinically apparent bully and confluent nature of rash help differentiate it from the other bullous disorders seen in younger children. The main DD is toxic epidermal necrolysis or TEN, but this condition shows mucosal involvement while SSSS does not have any mucosal involvement. If there is any doubt, the two conditions may be distinguished by histology. A frozen section may be of help for rapid diagnosis. The level of split in TEN is lower at the subepidermal level, but it is subcorneal in tetra S. Management. Treatment is with penicillinase-resistant penicillin analogs such as coamoxiclav, cephalosporin, and sodium fusidate. Clindamycin, which is a ribosomal inhibitor, is frequently recommended as the first-line therapy to the tetra S. If attack is severe, the drug should initially be given intravenously. Appropriate compensation must be made for heat and fluid losses and hyponatremia. Pain will also require treatment. Pneumonia itself may be a complication. Even with treatment, mortality is high, 2 to 10% in children, but usually reflects late diagnosis. The next disease we are going to discuss are the periporitis staphylogenes and Sweat gland abscesses. Periporitis staphylogenes is a term applied to the pustular lesions appearing in a neonatal skin as a result of secondary infection of malaria by Staph aureus. Such lesions may progress to sweat gland abscesses. The sweat gland abscesses are distinguished from furuncles by their lack of tendency to point or tenting, which is seen in a furuncle, and absence of tenderness, and plus the temperature is not very high. This is periporitis staphylogenes. It is distinguished from malaria pustulosa, which is not infective, not involving any bacteria, although is seen commonly in neonates. The Candida albicans and malassezia furfur may also cause pustulosis in neonate, and number of non-infective conditions like eosinophilic pustulosis. Neonatal staphylococcal cold abscesses of large fold, like groin and axilla, develop shortly after birth. Child may not have any associated fever or malaise, although fistula formation may develop, seen frequently in occipital, submandibular, and subclavicular areas. Culture of pus from lesions grows Staph aureus. Treatment with oral antibiotics is usually sufficient, and lead to rapid resolution of infection, although some children may require incision and drainage procedure. Omphilitis is a rare in developing world, but more common in developing countries and seen in 6% of the newly born infants. The mean age of development is 3.2 days. Characterized by redness and edema and discharge of the umbilical stump, cases may progress to cellulitis and deeper tissue infection. It is more common in protracted labor, non-sterile delivery, or cord care, prematurity, low birth weight, and some cultural practices such as application of tobacco ash. A variety of topical antiseptics and antibiotics are used. Use of hexachlorophane was popular until it becomes apparent that it could lead to serious neurotoxicity, particularly in the preterm infants. The best substitutes are the chlorhexidine, applied as the dusting powder, or aqueous solution rather than alcohol solution. In 1998, WHO has advocated the use of dry umbilical cord care wherever possible. Tetanus, diphtheria, and necrotizing faciitis may also occur as a complication. Such infections still responsible for high proportion of death in neonates in the developing countries. The necrotizing faciitis is a distinctive and serious kind of infection that can be differentiated from cellulitis, in which infection tracks along the various facial planes, causing thrombosis of blood vessels, which are running through the fascia, that results in decrease in blood flow and necrosis of the skin and subcutaneous fat and even muscles. In neonate, it may arise spontaneously, but most often is a complication of physical birth trauma, omphilitis, breast abscess, or iatrogenic skin wounds as a result of scalp electrodes or circumcision. The mother genital tract may be a source of infection. Initially, the infant develops straightforward cellulitis, affecting usually the abdominal wall. However, the child becomes abnormally toxic, area become indurated, discolored, and extend progressive. And this extension is quite rapid. Surface show pudy orange appearance. Purpura and occasionally bulla develop in the center of indurated areas, followed rapidly by frank necrosis. Destruction of superficial nerve results in local cutaneous anesthesia. Gas and crepitation may be clinical apparent or may also be seen radiologically. Fever is not invariably present. These are the areas of necrotizing fasciitis. A wide variety of bacteria is isolated, most commonly group A streptococcus, but also group B streptococcus, staphylococcus aureus, and Escherichia coli. In many cases, a synergistic infection of aerobic and non-aerobic bacteria may be responsible, and fungi are sometimes also involved. Antibiotics and sometimes antifungal therapy appears to be of limited value, as this is a potentially lethal condition, and there is a role of surgical debridement as well. Neonatal listeriosis. Listeriosis is an uncommon but dangerous condition in a neonate. The responsible organism is Listeria monocytogenes, which is transmitted to infection principally through contaminated foods. In pregnancy, it causes a non-specific mild influenza-like illness in mother, but leads to transplacental infection of the fetus. Maternal HIV infection may predispose to neonatal listeriosis. Products that are made from unpastured milk are common source of infection. Clinically, early onset and late onset form of neonatal lesions. The early onset lesions result from development of miliary granulomas followed by blood-borne dissemination of infection. Severely affected baby tend to be born prematurely and there is a high mortality. Postpartum studies reveal miliary granulomas in many organs manifest as scattered, discrete, gray-white papules or pustules 1 to 2 millimeter in diameter with a red margin and is probably a source of organisms for the culture. The back appears to be site of predilection, which are also seen in mouth and conjunctiva. Other cutaneous lesions are described in such babies that include purpura and morbilliform rashes. In late form, meningitis may also be affected. The symptoms of neonatal listeriosis include poor appetite, high fever, irritability, shortness of breath, vomiting, and rash. Diagnosis is by culturing the organisms from a wide variety of sites, including CSF, blood, urine, and from biopsy material. Treatment is usually with a combination of parenteral ampicillin with gentamicin or tobramycin, followed by a prolonged 3 to 4 week course of oral ampicillin. Ecthyma gangrenosum. Pseudomonas aeruginosa is common in hospital environment, and the infection are encountered or encouraged by widespread or use of broad-spectrum antibiotics. The weak mechanical defense barrier and underdeveloped cellular or humoral anti-immunity increase risk of infection. Most, but not all, in neonates who develop ecthyma gangrenosum have Pseudomonas aeruginosa septicemia, usually in context of prematurity, renal failure, neutropenia, and other immunodeficiencies like necrotizing enterocolitis and bowel surgery. Other bacteria have also been implicated like E. coli and Klebsiella. Clinically, it takes form of painful macular red skin or purple ecchymosis. The center develops either vesicles or pustules that rapidly ulcerate, and subsequently one or more ulcers occur, each with depressed necrotic skin, often black crusted center and raised edges. Perioral or perianal show group lesions. Infection is potentially dangerous when it occurs in setting of septicemia. See these lesions which progress from a scar to an ulceration and to healing. Appropriate parenterally administered combination antibiotic therapy is required. Awareness of this presentation in neonate is critical since its presence prompts the need of early treatment, as Pseudomonas infection carries a very high degree of mortality. Noma neonatorum or Chancrum oris. Noma neonatorum is a gangrenous disorder. Primary site of involvement is the oral cavity. Other sites rarely affected include nose, eyelids, umbilicus, scrotum, and groin. Reported onset is third postnatal day to 120 days. Noma neonatorum occur in low birth weight babies or premature neonates almost exclusively in the developing countries. It is frequently caused by Pseudomonas aeruginosa and almost invariably lethal in absence of appropriate antibiotic treatment. This is Chancrum oris. A similar condition is seen in older children with poor nutrition, delayed growth, and immunodeficiency. Treatment is with parenteral antibiotics, I've already mentioned, and require plastic surgery later to repair large defects. Surgical repair is generally delayed for 1 year post-resolution. The next disease to consider is the congenital syphilis. 15% of children born to mother with untreated syphilis will contract congenital syphilis, but fetal loss or stillbirth occur in 20% of the pregnancies. Skin is normal at birth. Initial lesions appear at 6 to 8 weeks postnatal, occasionally later. Site of predilection are non-genital sites, face and palm and soles. Lesions are reddish-brown in color. They can be macular, papillar, and larger and firmer than the acquired secondary syphilis. About 3% of the cases of the lesions are bullous with keratoderma and desquamation of extremities. Paronychia is common. Small, round, moist papillar lesions, the mucous patches, are frequently seen in mouth and other mucosal surfaces. These are the psoriasiform scaly lesions seen on the feet, with papillar lesions on the face and eroded lesions on the perianal area. Condylomata lata may be present in anogenital flexures or other flexural sites, that is between the toes and angle of mouth. Apart from cutaneous feature, the most frequent clinical manifestation of congenital syphilis are the hepatomegaly, splenomegaly, jaundice, pneumonia, and rhinitis. Congenital tuberculosis. The tuberculosis in a newborn is due to transmission of infection in utero and is a rare condition. The lungs or liver tend to be the prominent site of involvement. However, the skin manifestations are unusual. The cutaneous lesions may occur, and they are in a form of discrete umbilicated red papules up to 4 millimeters in diameter. This tuberculosis has high degree of mortality, and a recent preview from China rates the mortality as 43.48%. Neonatal candidiasis, again an uncommon condition. It is a relatively common condition that occurs in early weeks after birth in the form of oral candidiasis with or without candidiasis of the nappy area. Rash in the perianal area is deep beefy red with moist appearance, and often pustules are seen at the periphery, having a scalloped outline. The papules just spread beyond the margin and may be punctate red lesions, sometimes pustular, and these are called as the satellite lesions. It is assumed that infection is acquired. It should be borne in mind that frequency of vaginal candidiasis at the time of delivery is just between 20 to 25%. Occasionally, rash may become more generalized. Treatment is with topical anti-candidal creams and oral gels. Systemic neonatal candidiasis is particularly a problem for preterm babies or intensive care units where it causes septicemia and death. Often there is no associated skin lesion and treatment is with intravenous antifungal therapy. Congenital candidiasis. This is a rare condition. This is a rare condition seen at birth and is believed to reflect the maternal candidal chorioamnionitis that results from the ascending infection from the genital tract. 10 to 35% of the women suffer from candidal vaginitis during pregnancy, and 1% of them develop chorioamnionitis that can affect the fetus. It appears that Candida is able to find its way into the amniotic fluid without the rupture of membranes. There is no evidence that maternal antibiotic therapy or immunodeficiency in infant plays any role in predisposition. An extensive eruption of scattered pinkish red macules and papules is present at birth or appear within a few hours. From this macule and papule, a vesicular phase sets in, which is characterized by pustular or bullous lesions in another 1 to 3 days. More or less, any part of the skin surface is affected that include the nail, palms, and soles. In fact, palmar and plantar pustules are regarded as hallmark of congenital cutaneous candidiasis. So remember this. Paronychia may occur and isolated nail involvement is also seen. Oral involvement is absent, which is seen in neonatal candidiasis, but it is absent in congenital candidiasis. And nappy area is also appear to be spared. So there are quite distinct appearance of both congenital as well as neonatal candidiasis. So these are the typical pustular lesions on the hands and extensive erosions following the blisters on the trunk. When infection is confined to the skin, affected infants are generally well. Rash clears in a few weeks with appropriate topical antifungal therapy, for example, topical ketoconazole. Skin and mucosal involvement may be complicated by systemic candidiasis, particularly in premature babies. Systemic candidiasis is characterized by having pneumonia, hepatosplenomegaly, abnormal liver functions, and even meningitis, which is serious. Criteria have been proposed that indicate high risk of systemic involvement, and in all such cases, systemic antifungal therapy should be considered, and amphotericin B is probably the drug of choice. Studies have also shown the role of intravenous flucloxacillin prophylaxis in very low birth weight infants, which can reduce the chances of invasive candida. Colonization of skin by malassezia fervor starts soon after birth and progress until age of 3 months probably reflecting the activity of sebaceous glands during this period. The yeast has been a cause of systemic infections in infants who are receiving the intravenous lipid therapy. It is believed that malassezia furfur and malassezia symphodalis may be a frequent cause of red papulopustular eruption occurring on the face and scalp in neonates, a condition now widely termed as neonatal cephalic pustulosis. Presentation is sometime like this. Not all neonate with clinical presentation has detectable malassezia in the lesions. The rash is reported to have frequency of 10% in neonate as an outpatient in pediatric dermatology department, with pustules content showing malassezia furfur yeast in over half of the cases. A good therapeutic response with topical application of 2% ketoconazole for 15 days. Differential diagnoses include eosinophilic pustulosis of a scalp, transient pustular melanosis, scabies, neonatal acne, and infection with Candida or Staph aureus. So thank you very much. And this brings to the end of this lecture as well as chapter. See you next time with another chapter. And till then, goodbye and have a good day.